Very good evening to all my listeners. I am Dr. Sonali Jagati, OBG resident at SCB Medical College, Cuttack, having secured an All India rank of 3,546 in NEET PG 2021. Today I am here to discuss a recent advancement in the domain of PPH. Postpartum hemorrhage, which is one of the leading cause of maternal morbidity and mortality, has a new topic that has come up, that is PPH care bundle. Before going into what exactly are the components of the PPH care bundle, let's just brush up with the definition of PPH. According to WHO, any blood loss that is happening more than 500 ml, irrespective of the route of delivery, is termed as PPH. Whereas the RCOG gives clear-cut guidelines that the blood loss of more than 500 ml, irrespective of route of delivery, and has also classified it as mild and severe. Mild is when the blood loss is between 500 to 1000, and major is when it is more than 1000. Again, major has been classified as moderate and severe. Anything between 1000 ml to 2000 ml is moderate, and anything more than 2000 ml is severe. So these are the definitions of PPH. Quickly brushing up into the causes of PPH, as we all know the famous 4 T's, that is tone, tissue, trauma and thrombin. Now let's get into the topic proper, that is PPH care bundle. Now why exactly was this PPH care bundle devised? It's basically to recognize PPH early and also manage it, and also manage the refractory cases of PPH. What are the components? The famous acronym for PPH care bundle is MOTIV, or even motivate. So MOTIV stands for M is the massage, that is uterine massage. O stands for oxytocin, which is a uterotonic. T stands for tranexamic acid, and I stands for intravenous fluid. After exploring the uterus for any retained tissue and looking for the any trauma, then we have to assess the tone, and uterine massage has to be given. Next is uterotonics. Very important. The drug of choice is oxytocin. Oxytocin should also be given as a part of AMTSL and also in the management of PPH. For the management of PPH, you can give from 20 units to max 40 units. IM 10 units, and the rest IV, slow IV. IV should never be given bolus in oxytocin. The WHO recommends 20 international units in 500 ml of crystalloid, either RL or NS, which has to be given over 1 hour, and then it can be increased up to 40 units. Maintenance dose can be given 2.5 units per hour. Then the next important thing after uterotonics, of course, is giving tranexamic acid. Now, according to a trial which was done, that is the women trial, where it studied the efficacy of tranexamic acid, it has been found out that if administered within 3 hours of delivery, then tranexamic acid has a very good role in the management of PPH. It can be given 1 gram, and then it can be repeated after half an hour. Next, of course, is IV fluids, which is very important as there is blood loss. So to replenish that, we have to give IV fluids. Crystalloids should be given. 500 ml should be given in the first 30 minutes, and another 500 ml should be given over a period of 60 minutes. Now this was the initial management. Now suppose the patient is refractory to it. Then we have another guideline, that is PPH care bundle for refractory PPH. In that, what are the components? So there we have to give aortic compression, we have to give intrauterine balloon tamponade, and then use NASG, that is non-pneumatic anti-shock garment. So these are broadly the components of the PPH care bundle. And as a resident, it's very, very important to know the management of PPH and what are the drugs used, what are the steps involved, and how exactly should the management of PPH be done. Remember, first we need to stabilize the patient, and then the rest of the things can be done. Of course, this can be followed up by referral, transferring the patient, and maybe the ultimate management can be even surgery. But the initial management of the patient of PPH is extremely crucial and life-saving. So as a OBG resident, we have to know the PPH care bundle. I hope you found this informative. Thank you and bye-bye.